Well, welcome everybody. Thanks for coming. I am not sitting on the bridge at Lady Bird Lake in Austin. That's just a picture. So I figure it's better than my bedroom. We are thrilled to have a roundtable discussion today with Dr. Elizabeth Peckham. Dr. Peckham has been a very good friend of CAPS and has spoken to us before, but it's been a while, I think, Dr. Peckham. So welcome, Dr. Peckham, and thank you for coming. Now we're going to try our technology and see how that works. Here's the agenda for today. We'll meet Dr. Peckham. We'll tell you about the meeting goals, and then it's Q&A freestyle. Anything goes. Anything about PD goes. Not anything goes, but anything about PD goes. I'm not sure there'll be much conclusion because you'll probably get all the conclusion answers you'll need from Dr. Peckham. I will tell you about an upcoming CAPS event that we hope is pretty fun and you enjoy. While we're here, why is CAPS still in business? CAPS is still in business because Parkinson's disease is still affecting more than 1 million Americans. We all know what it is and the cause is unknown. The good thing is it's the only neurological condition in which medication exists that can moderate symptoms. And we all know that we rely on the meds to help us get through peaks and valleys, and it's only diagnosed clinically. There's not a lab test for it, which is kind of frustrating when you're getting diagnosed with Parkinson. At least I was frustrated with that. I said, you can't take a blood test? Welcome back, Dr. Peckham. Dr. Peckham specializes in the diagnosis and treatment of movement disorders such as Parkinson's disease. And this is going to be a test for how well I can pronounce these things as a Parkinson's patient. So Parkinsonism, essential tremor, Myoclonus, Tourette syndrome, Tics, Ataxia, Dystonia, Restless Leg Syndrome, Huntington's disease, Tardive Dyskinesia, and Psychogenic movement disorders. Whew. I need to take a breath now. Dr. Peckham also has extensive experience with the evaluation for and programming of deep brain stimulators. And that's Botox, right, Dr. Peckham?
Right.
Botox. So here is a little bit about Dr. Peckham. And it's quite a list. I won't go through it for you, but I just wanted you to see all the qualifications and how this is. Dr. Peckham is one of the top people in the field. And here's her background in education. I'll leave it sit there for a while. Usually people read these things and you get lost in the reading of them. But I think when you see it visually, you're like, wow. As in Boston, we'd say she's wicked smart. Here's honors and awards. The Malvern Divine Kinsey Scholarship, 1998, Resident Scholarship at American Academy of Neurology Annual Meeting, Chief Resident, pretty good background, the best of the best. What are the meeting goals? Well, we're going to provide an informal forum for Dr. Peckham to discuss PD. The questions have been submitted in advance in order to provide opportunity for more thorough responses. Anything goes. We want to inform and educate, and obviously have fun if we can. I think we can. Right, Mary?
Absolutely, and I'll just add something to this. As what I said a moment ago is that if you have a question, feel free to send it just directly to me if you in the chat, or if you feel comfortable asking it. Dr. Peckham, I don't know how you want to do that during the presentation, but or Victor, but if someone has a question, what would you like them to do if they feel comfortable asking themselves?
It doesn't matter to me. I'm happy to take, we've got the submitted ones, but I'm happy to take ones in between. If you want to just, and maybe, interrupt and just say, before we go on to that, we have a live question. We can do it that way.
Okay.
Yeah, I'm flexible.
Okay, awesome.
That'll work.
Good
Mary,
deal.
just give me the high sign, Mary, and I'll slow down the thumbs up. Okay, Dr. Peckham, can you comment on the research regarding the protein alpha-synuclein and the impact it may have on a cure?
Sure, I'm happy to do that. Can I share screen now, or are you still the host? Let's see.
I'm still a host.
Okay. I think Mary, you're on mute still.
We'll
There
get
we
through
go.
this. Do you need to share your screen?
I do, yeah. I've got for some of these, I just prepared a web link just for some visuals. I think it's easier to explain than say paragraphs worth of words. Let's see. Okay, so you're the host. Let's see if it'll let me. Do you think you have
You
to make
should
me
be
the
able
host?
to.
Okay, let's see.
Hang on just a second. We'll do this real quick. There you go.
Okay. Yep. Yes. Okay. So let's see here.
Victor, you may need to unshare for just a moment.
Yeah, I think
Stop
this.
share.
Unshare for just a moment. We'll get through this, guys. There you go. All right, Dr. Peckham, you can share your.
Yes, it should let me share.
Mhm. You are the host, so you should be able
Yeah,
to.
let's see, I'm just pulling it up.
Okay.
Here we go again, Jim.
Okay, let me see here. Oh, I see. Okay, so I wonder, that's the one I need to do right there.
Should I sing like hold music while we're waiting, Mary?
No. No.
You heard me sing before.
Mary.
No. I'm kidding.
No music. Sorry, now I've lost mine. Let's see here.
It's okay. We'll just work with it and make it happen.
No, this is going to be a test of everybody's patience today, I have a feeling. So
That's all right. We'll make it work.
It gives more time for meds to kick in, Dr. Peckham.
Right, we should have some jokes or something prepared. How about that? Okay, share. It's on
Jokes?
this
I have
for me.
plenty of
Okay.
jokes.
No.
No jokes. All right, can you guys see my screen now?
Yep, sure can.
Perfect. Okay. Now that we got it figured out. So this is a really good question. It's also a very detailed question. So I thought it'd be helpful to put up some pictures. Also, just so everybody is aware, I have got all of these links to what I'm going to share today. I'm going to send these to Victor, or actually I already sent them to him, so he can send it out to the group. So don't feel like you have to write anything down. He can send it out after the meeting or next
I will
week.
do that. Happy
Yeah.
to do
So.
that.
So this is kind of a picture of where alpha-synuclein is in the cell and how it gets accumulated. And basically what happens is all these little yellow dots here are little pieces of alpha-synuclein, and they become clumps. And so there are several ways to help get rid of those clumps. One is immunotherapy. One is trying to clear the clumps out of the cell. One is trying to prevent them from clumping together. And then one is here, this receptor block where you prevent the clumps from even being taken up into the cell. So that's kind of the idea. So alpha-synuclein itself has a lot of ways. The reason why I wanted to show that is because there's a lot of ways to block alpha-synuclein. And there's a couple other pictures here.
Dr. Peckham, what have they discovered that all Parkinson's patients share regarding alpha-synuclein?
Yeah, so all patients with Parkinson's end up developing these clumps, and this is a picture here of a healthy cell and then a Parkinson's cell. So what happens with Parkinson's is all these little pieces of alpha-synuclein, which is a protein, clump together, and they kill the cell, and they basically kill the dopaminergic cells, so the cells that are making dopamine. So this is kind of a healthy cell where you've got normal function of the synapse and the cells functioning happily. But when you start taking up these little pieces of the protein and you get them into the cell, it kills all these things that are trying to keep the cell alive. And so that's why the slide that I showed previously, where you can block that alpha-synuclein in many, many different ways, is a target for Parkinson's, to try and prevent the alpha-synuclein deposition and to prevent killing the cell off. So there's a lot of ways to do it. Right now, I would say, as far as current studies that are out, there's a phase 2 study through Roche that is targeting, some of you may have read about, but that's targeting this immunotherapy pathway, where there's an immune compound that is basically binding up that alpha-synuclein, and it prevents it from getting dropped into the cell. So presumably you can either stop or slow progression down of Parkinson's if you can stop these clumps from depositing into the cell and killing the cell.
Gotcha.
Does that make sense?
Yeah. They don't have medication yet to do that, right?
Well, even if you're on or not on medication, I mean, if you've been diagnosed with Parkinson's, this alpha-synuclein, if you were able to take a picture of the brain tissue and look at it under the microscope, you're going to see dopamine neurons that are killed off and that have this alpha-synuclein clumping happening in the cell. So regardless, I mean, with the diagnosis of Parkinson's, this is already an ongoing process. So
in a normal person without Parkinson's, there's no
correct.
buildup of alpha-synuclein. It goes, but alpha-synuclein exists in
right.
But
it exists, but it exists, but it doesn't form these clumps to kill the cell. So alpha-synuclein is found in normal healthy cells, but it doesn't clump together as it does to kill the cell off, as it does with Parkinson's. Same type of thing with Lewy body. Alpha-synuclein is the protein that's the problem with Lewy body.
So we got to figure out how to beat the clumps.
Exactly. So you got to figure out a way to prevent those clumps from happening. So that's why when you look at how to prevent the clumps, so you can either try to bind the clumps up here, this immunotherapy way. You can either try to clear the clumps out. So lysosomes are normal. They're basically kind of like the trash center of the cell. You take your trash out, take it to the curb, it goes into a landfill. So they're trying to take proteins and things that have been broken down, get them out of the cell. But all of this starts to fail with Parkinson's. So you've got the clumps forming, you're not able to clear it out of the cell, so they build up, they aggregate, which is a problem, because in normal healthy cells, these little dots in themselves are not a problem, but when they start forming these chains and these clumps and these folded proteins, that's where it gets to be an issue. So these are all ways of targeting alpha-synuclein and trying to prevent it from killing off the cell.
Interesting.
So,
does anybody have any questions about that or anything else I could try to clarify? No.
Get the clumps.
Okay, get the clumps, right. All right. Do you want to go on to the next question?
Yeah, I have to go back to the slides because I can't.
Here you go. Stop share. So I stopped sharing, and I think Mary has to reassign the host.
Yep. There you go. Victor, go for it. You're good.
Let's see if we can do this time without incident.
You got it.
Can you? I just did that one. I am currently on a medication regimen of carbidopa, levodopa, Azilic, pramipexole, and entacapone. My doctor has asked me to consider adding amantadine. If I'm pronouncing that right. There seems to be very many side effects. How do you assess the benefit of the medication versus the downside of the side effects?
Okay. I don't have any slide to share anything on this one. So I'll answer this the best I can. It's always hard when people pull in kind of, very personal situations on their medication management without knowing the whole picture. But obviously, every time you add a medication, you do have a higher risk of side effects. And amantadine itself, common ones would include dry mouth, constipation. And I always tell patients, anytime you are adding another medication on to your regimen, your risk of hallucinations also goes up. So So that's the downside. What I would say, I mean, my advice would be just to revisit with your doctor and say, do you need all of these medications? I mean, presumably carbidopa, levodopa, and entacapone, you need both of those to have as good an on time as possible. What I do see in some patients is that they were put on Azilect a long time ago. They're not really sure if it's helping or not. Same with pramipexole. And if you're not sure, trying to whittle down the amount of medications you take, I think can be important. So if I have somebody that, I mean, I took this question as if somebody came to me for a second opinion, what would I do? And the first thing I would do is just have an honest conversation. Do you remember how you felt when you started Azilect or pramipexole? How did that make a difference for you? And oftentimes you can even just reduce the doses of some of the things you're taking, the pramipexole and the Azilect in particular, to see, do you feel any different? And then making a decision.
So you can do that on your own, kind of.
Yeah, so I would just say talk to, you know, for this question, talk to your doctor and say, I'm really concerned about the number of medications that I'm on for Parkinson's. Do I need all of these? Is there any that we can try getting off of? Because, you know, I agree, the more medications you add on, certainly for a lot of patients, we use a medication cocktail, but every time you add something into that cocktail, the risk of side effects does go up, and it has to be a risk-benefit ratio.
That's a good approach. Thank you, Dr. Peckham.
We have a question, I believe, that's probably from our last slide and the things that you shared. It says, how far away are they from developing these treatments that we've been talking about?
Yeah, so with the alpha-synuclein in particular, right now, the study of the immunotherapy agents are well underway. So there are a couple trials right now through Roche. There has been a trial that's been completed. It was a phase 2 clinical trial, and we actually did it at our center. We have patients currently in that trial. And it is an IV formulation of an immunomodulator that blocks the proteins binding and going into the cell. And it was a very specific trial. It was patients newly diagnosed within 3 years and on no medications. So they really tried to pick the simplest of Parkinson's. That way there's, you know, less risk of, you know, other possible effects. So, so that was the first trial that was done. The name of the trial is a Pasadena trial. The next trial that is now ongoing currently, and we do have this at our center as well, is called the PADOVA, P-A-D-O-V-A trial. And the way that they're staging this one in is it's patients, again, newly diagnosed within 3 years, and they can either be on an MAOB inhibitor, which would be Azilect, selegiline, Xadago, or they can be on a low dose of carbidopa, levodopa, less than 450 milligrams. So patients that are newly diagnosed on low dose medication are enrolled against drug versus placebo. That period of time is a year that they get drug or placebo. It's a 50-50 chance. And then after a year, they get on to what's called the open label, and then everybody gets drug and they're monitored for safety, efficacy. We do scales and follow that. So, you know, my guess is that as long as these continue to look positive, the first trial was positive. It did look like it slowed progression. So that's why the PADOVA trial was then started. But I'm hopeful that the next step will be, you know, patients with moderate Parkinson's, maybe not as restrictive on the amount of medications being on, and seeing how it changes the course. So these are happening. These trials are ongoing.
Dr. Peckham, it takes a long time to get a drug approved by the FDA.
It sure does.
What phase is this in?
Yep.
Phase 2, phase 3, or?
Phase 2. These are both phase 2 trials. They're looking at, phase 2 really looks at safety and efficacy. Phase 3 are larger, more involved trials, but they're phase 2.
Well, hopefully this answered the person's question.
Yeah.
Feel free to go from there. So
Next question. Are there certain foods that should be avoided because of PD medications?
Yeah, it's a good question. So I would say it depends on the patient. PD medications in particular, the ones that have the food interaction, are any compound containing levodopa. And the issue with levodopa is that protein, if you take protein at the same time as your medication, protein would be meats, beans, eggs, nuts, dairy products. At the same time, you have the potential to block the uptake of the carbidopa-levodopa. So it does not harm you per se, but you don't get the full effect of your medications. Different patients seem to have a different level of sensitivity to this. I see some people, again, who either transfer care or come to my clinic, and they tell me, oh, they always eat breakfast every morning and they have eggs and bacon and they take their medicine and they're fine. The general rule is that it does decrease the absorption of the medication. And because of that, we say to try to take your medicines either 30 minutes before you're going to eat anything with protein in it, or an hour after, just to give your body time to absorb the medication and then the food afterwards, or get through the stomach with the food and then the medication. I do have some patients that are really, really sensitive to protein, and all day long, any protein that they eat seems to affect their medication. There is a diet called the protein redistribution diet, where patients try to limit protein throughout the day and really have all their protein in the evening. I don't think that is necessary for the majority of patients, but some patients are very, very sensitive to that.
Hey, thank you.
Sure.
I think the next question kind of tags on to that a little bit.
Mm-hmm.
Why should protein?
Yeah, so that's right.
Yeah, I think you just explained why.
Yeah, so, and I think 90 is a little bit long. I mean, again, it depends on the person. If you read the package insert that comes with your medication, it usually says an hour before or an hour after. For most patients, I really think a half an hour. If you take your medication, you just want to get the medicine absorbed and you don't want it battling with the protein to get absorbed. So most people 30 minutes to an hour after. I think you got to be careful being too restrictive too, and maybe check it out and see how your body works with protein, because it's really hard if you're taking medications multiple times a day and you're trying to avoid protein every single time. And it gets to be very taxing. So,
Well, as I've talked to Parkinson's patients through CAPS, there's urban legends that develop, and I think this is one of them.
yeah.
Yeah.
This isn't my question, I'll be honest. When my reflexes are tested, I get no response. They bang on my knee, they bang on my elbow, I get no response. So if somebody surprised did something to me, I have reactions that are normal or good. Will that disappear also?
Yeah, so I actually had a thing that we don't have to share the screen on this one, but I do have a web link for you. So, when you test reflexes, they're really based on the stretch response of where the muscle tendon attaches to the belly. And when your neurologist tests that, they put a thumb or finger on that tendon and tap. So it's really more the spinal's response, and that's affected by a lot of things. When we test reflexes, we're really looking for symmetry. So we want to make sure it's equal one side versus another. And a lot of people do have either decreased reflexes all the way across or increased all the way across, but it really denotes more pathology in the brain or spinal cord. If it's down everywhere, it's not really the same type of effect as your personal responsiveness. So
Thank you.
kind of a different mechanism, I guess.
Well, it just surprised me all the time when they
Yeah.
do the hammer and nothing happens, but then I can catch a ball.
Right.
It just
Going back to, before we step to the next question, going back to talking about proteins, we had someone ask about, what about plant proteins?
Yeah, plant-based proteins can be an issue too. So it's really anything with protein. When you think about, I mean, plant-based proteins are going to be any legumes, chickpeas, beans. So it's the same thing. Obviously, the higher level of protein, the more protein you're taking in, the bigger an issue it can be for some people. But yes, plant-based are an issue too.
Great, thank you.
It's a good question.
Next question. Does PD make you more susceptible to COVID-19?
Okay, so I actually have a thing to share on this, which I think I probably should share, but the short answer is no, you don't get more susceptible, but you do have, I think, a higher chance of a worse outcome depending on your symptoms. And specifically, the example would be, patients that are a higher swallowing risk, have a higher swallowing risk, higher risk of aspiration pneumonia. Obviously, if you're having something affecting your lungs, you're going to, again, really increase that risk.
You're able
I'm
to
gonna go
share if you'd like.
share my
Mhm.
screen. Yeah, so I will share it. Let's see. Yes. Okay.
I stopped sharing, Mary.
Yep.
Yes.
This will be smoother this time. We don't have to do jokes. Okay, so
Right.
here is, this is that spinal cord reflex arc. So I do have a link on this, but this is just, it just shows you the reflex arc versus if you touch something versus when you tap on the reflexes.
Mhm.
So you can look at that later.
We'll look at
I
that.
thought this was good. This is from the APDA, the American Parkinson's Disease Association. And it's really a lot of questions about, because I get this a lot in clinic, and this changes. And so they really mention that in here as well, that, you know, it's an ever evolving field for all of us. But these are questions just about COVID-19, studies of long-term effects of Parkinson's, the vaccine with Parkinson's, should you get a vaccine? How's the Delta variant affect somebody? So I just thought this is good. Again, this will be in that email with the link, but I thought these were really good questions. And sometimes when we ask one question, then we have more, so.
That's for sure.
And you want me to stop sharing?
Yeah, let me see. We've got a couple of questions.
Sure.
Hang on. I gotta,
There's a question from Robert Camper.
yep, hang on. I've got to get, now I can't get to my chat. Okay, hang on, folks. I'm so sorry. Okay, let's see. I've seen in the paper a neural regeneration research journal, volume 17, number 5, May 2022, published online September 17th, 2021, titled From Regenerative, I can't talk, Regenerative Strategies to, my vocabulary is terrible, pharmacological, fine-tuned treatment for, Robert, you're killing me, fine-tuned treatment for PD. This seemed to be the promise in, and I'm not even going to try to say that, if you can see that, Dr. Peckham.
I can see it. Yeah, I can see it,
yeah,
for N-acetylcysteine and stem cell.
Yeah, I'm not even going to try.
It's a good question. So I have not personally seen this article. There are thousands of articles out there. I can tell you just from the title of it, when they call neural regeneration research, it's going to be something that's very much cell-based research. And I think there are, again, probably thousands of compounds that could be great as far as potentially slowing progression, being neuroprotective. There are so many compounds being looked at for that. I think the only way to really know when you put it in a human and really find out, are these compounds neuroprotective, is to have large clinical trials. And it's hard with a lot of the supplements. I mean, this is on a different topic, but there's not really supplements that I recommend. There are many, many out there that they say really help slow progression of Parkinson's. But the problem is we don't have large scale trials to show that they are neuroprotective. And I think we all thought that CoQ10 and creatine and, you know, there are others were neuroprotective based on this idea that in the cell, this should theoretically work. But there's so many factors that go into when you have a human taking a supplement in, how does it get absorbed? Does it cross the blood-brain barrier? In what level? You know, and so downstream, is it enough? Or, you know, if there are other factors going on. So I think there's a lot of supplements out there that could show promise. It's just hard to test them. And in order to do these large scale trials, you got to invest a lot of money. And when it's a supplement that's readily available, it's hard again to find a company to do that. So.
Yeah. So I'm assuming that's based on the next one that said recommend. So anyway, all right, Victor, please go right ahead. Continue. We're getting good at this.
No.
Bad,
Getting it down.
Just
Next question. There you go.
okay.
All right.
This is kind of, you've been addressing this as we've been going. So I don't know if you want to add more to this, but
Yeah, I do have some stuff to add, and I of course need to share my screen. So this is
That's
this
okay.
is a huge topic,
No,
huge topic.
we're
But we're
fine.
getting really good at it. So
Yeah, so here we
didn't
go.
I hear Dr. Peckham at one point that last year 5 PD drugs were approved?
yep.
Which
There have been
is
several that have been
phenomenal.
approved, especially for off therapies. I know that's a question coming up too, so we can talk about that.
Go ahead and unshare.
Oh,
Oh, I
And-
forgot. I have a role in this unsharing.
Yeah, there you go.
I've got
All
mine
right, Dr.
coming. There we go. Okay, I'm going to start
Um,
closing out some of my tabs here because I got so many open. Okay, so I've got a couple things to share as far as medications and clinical trials, because this is a huge, huge topic. And obviously, I have one slide in particular that's going to show everybody really, I think, how big it is. There's a couple ways to get information as far as like what's the current and latest status. The Michael J. Fox Foundation does a great job of pulling up medications and trials. And one thing I like about how they categorize them is they talk about stages of development, which is important. They also talk about the therapies that are out there. So one of the things we talked about was alpha-synuclein. And if it tells you what it is, and then it tells all these trials. So this is a phase 1 trial. This one's a phase 2, phase 1, phase 1, phase 2. So this is one I had mentioned as far as the immunomodulator. And then there's all these other ones, again, that these are looking at neuroprotection, and it goes through all them. So there's a ton of information in here. Then it goes into motor symptoms. So it talks about how to deliver levodopa better, non-dopamine approaches, off rescue, gene therapy. So again, you could go through each one of these. It talks about non-motor, what's happening with anxiety, constipation. Largely what Michael J. Fox puts on here too is the ones that they are supporting. So it's a great overview. I like the way it's very easy to read, very easy to get information on. I pulled up a review on Parkinson's. This is a more complete list, Parkinson's disease drug therapies in the clinical trial pipeline 2021 update. And I just want to, if I can get down to it. So this is all the drugs in development for disease modifying therapies, because there are thousands. And this kind of categorizes them. These are all the phase 1. So phase 1 is really just looking at safety. Phase 2 is looking at safety and efficacy. Phase 3 is looking at safety, efficacy, and benefit against placebo. So this is disease modifying. So again, this is just trying to slow or stop progression. And it tells you how they work. So targeting alpha-synuclein immunotherapy, kinase inhibition, anti-inflammatory cell therapy. So it's kind of overwhelming, but it's also hopeful, I think, because there's so many things out there. This is that, and then they break it down by phase 1 trials, phase 2, phase 3. And again, they talk about, these are all the different drugs here looking at in development. So I think, I like seeing this because it makes me realize there are just so many things out there that are being done. And, when you look at the statistics going from phase 1 to 2, there's a percentage of drop off. I think it's maybe 50% that make it to phase 2. And I think it's another 50% that make it to phase 3. So you do lose some of these because they don't prove that they're beneficial enough to move on in drug trials. But these are all the phase 2 trials. These are the phase 3 trials. So anyway, just lots of information out there.
Dr. Peckham, I'm glad of this, but why is Parkinson so popular with the drug companies?
Well, I actually don't think it is. When you compare Parkinson's trials with cancer, heart disease, diabetes, it's really any neurological syndrome is there's not near as many, because there's not near as many people affected globally. There's many people with Parkinson's, but when you compare diabetes and high blood pressure, heart disease, cancers, many more patients are. So I don't know that I'd say that it is popular, but I think we are seeing so many more trials than we were. And I think that's for a couple of reasons. One is people live longer. So part of the reasons why people are living longer is because drugs have been developed to cure cancer and heart disease, or maybe not cure, but ameliorate heart disease. There are surgical therapies, high blood pressure, diabetes. Years ago, patients and people had a much shorter life expectancy, and they would, die of a heart attack or cancer because there were so many untreatable conditions out there. And now that we're treating those things, people are living longer. And if you live longer, you're at a much higher risk of developing anything neurodegenerative, Parkinson's, Alzheimer's, other dementias. It's just a higher risk.
So with these, a question goes, so regarding the relationship between DBS and the medicines, are there drugs that work better with DBS? And if so, why?
That's a good question. So I wouldn't say that there are drugs that work better per se with DBS. It really depends on the individual patient. Most patients, when they get DBS, we try to drop down their medication as much as possible. And the average is about 50%. If you can pull people completely off of medication, that's obviously ideal. Sometimes that's hard to do. And it really depends on the individual patient. As much as we always think about any levodopa preparation being the gold standard, some patients really have a great response with a dopamine agonist like Mirapex, Requip, Nupro. Some do really well with MAOB inhibitors. Some do well with amantadine. And so it's really, you really have to know your patient and know what helps them. It's very individualized.
Another question that came up was, what is the best rescue therapy to date?
Rescue therapy mean for an off period, I'm assuming? So there's,
I don't know if the
I would
person
imagine that
can-
that's the
Yeah,
question. So rescue therapy, there's several. And I would say, again, the best depends on the person and probably
yes, they said
trying.
yes, that was it.
Yeah, rescue.
Yeah.
Okay. Just so I make sure I'm answering it correctly. So there are several rescue therapies. I mean, an old one that's been around a long time is Apokyn, which is an injectable form of apomorphine. So if patients are off, usually with an injection, they'll turn on within 10 minutes or so is about average. There are two newer rescue therapies. There's Inbrija, that's an inhaler of levodopa. So that's contraindicated in somebody if they have asthma or other pulmonary diseases. But some patients, it really, really works very, very well if they don't have that condition. There's Kinmobi, which is a sublingual apomorphine. It's basically a thin strip that you put under your tongue for an off episode. You can also use oral dissolvable carbidopa levodopa. It's Parcopa is the brand name, but it is generic, and you can do that for rescue therapy. So there's lots of different things out there. And then really trying to, and this is hard, especially hard in some patients, but trying to get your medications the best that you can to where you're having less off episodes too.
Okay.
All right, I'm gonna,
Off episodes we're all familiar with.
yeah. Okay, there you go, Victor, you ready to go?
Okay, I'm ready to.
I'm going to stop sharing. Close out some of these tabs. There we go.
There you go. We're getting this. We're getting
I know.
this.
We're getting it down.
Thanks
Okay.
for your patience, everybody. So,
Why is it important to take medication at the same time each day?
Yeah, it's a good question. So I would say early on in Parkinson's, if you're first being diagnosed, first starting on medications, it's not as critical. You can probably space them out longer. If you miss a dose or you're late, maybe not as big of a deal. But as Parkinson's goes on and over time, the responsiveness to the medication in some ways wanes. You need more medication to get the same effect. And either more medication or a shortened interval time. So instead of maybe taking your medicines every 6 hours, maybe you're taking them every 4 or every 3 or every 2. And for patients, as they get more advanced Parkinson's, for some patients, once they hit an off, it's really hard to get caught back up again. Again, somebody newly diagnosed on minimal medications. I have a lot of newly diagnosed patients on carbidopa levodopa 3 times a day who say, I don't know if I even have an off. I don't really know what an off is. It's because they don't have an off, because they're generally doing pretty well on even if they miss it or take it late.
Yeah, but when it gets you, and it eventually does, you know it.
Yes, right. As time goes on, and then it's really hard to get on, and so it does become more and more important to take it on time.
Okay. These questions lead right into each other.
Yep. Yeah. So
go ahead. That's fine, Dr. Peckham.
do
Go
you
ahead.
want me to read it or?
No, is there anything, I'll read it. Is there anything I can do to minimize the off period that occurs in different degrees of severity usually in 30, 40 minutes of the next cycle. And then
Yeah.
30, 40 minutes to kick in. So you get
That's
about an hour of stiffness and
Sure. Yeah, because you're waiting for it to kick in and then, and it's waiting for your next dose. So there's a lot of things you can do. I mean, there are multiple different formulations of levodopa. So if you're on our immediate release levodopa or even the CR Cinemet dose, Rytari is a newer formulation. Some people, it really does help these off periods. So sometimes changing formulations, sometimes adding something like Comtan or entacapone to help extend the carbidopa levodopa. Sometimes adding a dopamine agonist, and especially a long-acting one. So there's Nupro, which is the patch, there's Mirapex ER and Requip XL. All three really showed less off time in patients. For some patients, they may be inhibitors, help that as well. So there's a lot of add-on therapy. Amantadine does have a long-acting. There are two long-acting formulations, one that is approved for off time. Both are approved for dyskinesias. There's Gocovri and Osmolex ER. So they're both a once-a-day amantadine also. I think even though the Gocovri, I don't think has the, the Osmolex doesn't have the off-time indication. That's just typically what we see, less dyskinesia, more on time. So there's a lot of things you can do. You can also take your medicines more close together. And you can, or you can take a little bit more medication per cycle, just depending.
okay.
So what patient's conditions suggest the use of Duopa?
Duopa. So what suggests Duopa? So I would say off time is a big one. So off time and dyskinesia. If you are really struggling with off time, I think of the Duopa patients and the DBS patients. I know there's a question coming up about this as well. But I think of those patients in the same category. So Duopa, for those of you who may not know, is an intestinal gel formulation of carbidopa levodopa. The procedure to get Duopa is basically, it's a tube that goes into the stomach, similar to a feeding tube. But one nice thing about it is there's a tail that attaches on the inside of your body to allow the medication to actually be distributed into the upper part of the small intestine rather than the stomach. So you can avoid some of the protein interactions because you can eat better around it if you're somebody that's really sensitive to that. And if you have off time or you have dyskinesia, I think Duopa for some patients is a great option, similar to DBS as time advances on. Patients do not have any restrictions as far as Duopa goes with cognitive impairment. So when you're thinking about DBS, we always do a neuropsychological test to make sure there's not cognitive issues. If that is found, I've had some patients that were looking at doing DBS and then we felt that they were not a candidate because it may make their cognition worse by getting DBS. And so Duopa was deemed a reasonable alternative, or patients that may not want DBS for other reasons.
Great.
Okay, thank you.
Mm-hmm.
Moving right along. This is a long one. Besides medical treatments, is there anything a person can do to decrease their drooling? Some background, my husband had drooling during the nighttime. Then in June 2020, he had DBS surgery in which he suffered a small stroke during the procedure, and now he has constant drooling. Since he is trying to get his speech back, he does not want to do Botox. That's a unique one.
Sure. So, I mean, there's several things. One is I'm assuming this patient is probably already in speech therapy, swallowing therapy. There's specific therapies to do to try and help the swallowing. And if it's patients that have drooling, it's really not that they make more saliva. It's just you don't swallow it as reflexively. So it tends to pool in your mouth. It starts as nighttime drooling on the pillow. And then as time goes on, it becomes more daytime. There are oral medications. Pretty much all of them can have cognitive side effects. So they can cause confusion and dizziness and things like that. But sometimes with low doses, they're tolerated. So there are oral medications. There's also atropine eye drops you can put under the tongue, and it just dries up the secretions a little bit. Can cause bladder issues with urinary retention if this patient is sensitive to that, but that's another alternative.
Mm-hmm.
Eye drops, really?
Yeah, they're eye drops. They taste bad, but they're pretty effective. So and they don't have the cognitive issues and
yeah. Interesting.
I guess you can put up with the taste if it works.
Yeah, goodness.
Dr. Peckham, what should I do if I forget to take my medicine and it's really too close to the next dosage time? Should I still take it without having to worry about changing the next scheduled dosage? Or should I just adjust future dosage time for that day?
Yeah, it's a good question. So I usually tell people if they remember pretty quickly, which it sounds like this person, is not remembering quickly. If you remember pretty quickly within an hour or two, I would take it and just readjust. If you're close to your next time, skip it and then just get back on schedule. And if you need to readjust a little bit, readjust. Again, in somebody with early Parkinson's, maybe not as much of an issue, but later stages, this can be a much bigger deal.
Okay, makes sense.
So let's see. Question was, are there going back to the eye drops? Are there eye drops over the counter? Are these eye drops over the?
Yeah, they're prescription.
Okay. Okay. And the next question is, how much does heavy exercise help?
Yeah, that's something we haven't really talked about. So exercise in and of itself is very, very helpful. So I think a combination, I'd say heavy exercise depends really on the person. I mean, I think if you can do high intensity exercise, it's great. Certainly I like people to exercise and not get injured, because if you get injured, then you can't exercise and we're right back where we were. But I do think a combination of, if you can do it, high intensity exercise, stretching, and light weights at least is a good regime. I get a lot of questions about how much exercise, how often, what types of exercise. My common sense kind of recommendation is do what you enjoy, because if you hate doing something, at some point you're going to stop doing it. So try to find something that you enjoy. All exercise with Parkinson's is beneficial. So whether that's taking a walk or doing yoga or boxing or, whatever it is that you enjoy, if you know that you are not going to do exercise on your own, really looking towards either group exercise or getting a personal trainer.
Excellent.
One other question.
Too.
Yeah, definitely. One question coming back from the Duopa. Do you have patients with both DBS and Duopa?
I do. Not very many. I've had total about 4.
Mm-hmm.
But yeah, and I've had a couple that did Duopa first because they said no matter what, they were not having brain surgery. They did not want DBS. And so they did that for a few years and then got to a point where they said, okay, I want to do DBS. And then I've had some that came to me with DBS and we were still having a really hard time, either with off time or dyskinesia. And then they got Duopa after, so.
Okay.
Dr. Peckham, in moments of freezing, what is your recommendation to help get moving again?
Okay, I got a screen share for this one.
Okay, hang on.
I just have somebody push me usually.
Victor, unshare your screen, please, sir.
Okay, I'm ready. I'm on top of it.
Okay. Dr. Peckham, you are ready to go. Oh, wait, no,
Right.
hold on. I'm getting there. Okay, got it.
Okay, let me close some of these out.
Mary, you got this down pretty good, Mary.
We
I was
both
going to
do.
show
All-
this.
All 3 of us do.
There's a couple things too. I had this for one of the earlier ones, but I didn't want to take the break for it. But this just shows like on-off fluctuations with levodopa. So when you're early PD, you tend to have this good, nice on, moderate. It tends to be more this fluctuation. And then advanced, you may have times where it really peaks and you get this, dyskinesia. And then you have times where you really can't seem to get on. And this is more where you see dyskinesia. I have a couple things for tips for freezing, because there's actually a lot out there. So this is a video about how to get unstuck from a Parkinson's freezing episode. This is Sarah King. She's a physical therapist in Austin, and it's a 3-minute video. I can play it, or I can you guys have got the link. Would people like to see it, or?
Yeah, why not? Let's see what we got.
It's 3 minutes, so it's pretty short.
Yeah.
I played it earlier to make sure it worked. She calls it the 5S method. So let me play that.
Sound?
I don't know if you guys can hear her.
You share your sound? When you share your screen, share your sound?
Does it have that as a choice?
Yes.
Hmm. It says screen sharing, recording to the
And then down at the
cloud.
other side, it says share sound.
On more? Oh, share computer sound. There we go.
Yeah.
Got it. Oh, new one. Okay.
Being stuck when you're trying to do
Yes, here.
something that's usually automatic or repetitive, like walking, talking, writing, or getting up from a chair. Usually freezing occurs because your brain is having trouble multitasking. Maybe you're trying to walk, but it's really crowded, or there are lots of obstacles like turning a corner, or you have to walk through a door, or maybe go from a wood flat surface to a carpeted rough surface. And usually freezing gets worse when you're fatigued, stressed, or anxious, which most of us are at some point in the day. So while freezing can be really frustrating, I know a couple great techniques that you can use to help you get unstuck and on with your life. So the key to getting unfrozen is bringing more mindfulness to the task at hand. If you're more mindful and aware of what you're doing, then your brain isn't multitasking as much. It can focus on the task at hand, and you can get out of there and on with your life. So I use a technique called the 5S method with my clients, and I want to teach it to you right now. The next time you find yourself frozen in place, use the 5S method. Number 1, stop. The more you fight it, the worse it gets, so stop moving. Number 2, stand tall. This helps you get in an optimal position to get moving again. Pick your head up and squeeze your shoulders back so your back's flat. Number 3, shake it off. Take a deep breath and relax any areas you're holding tension, usually in your hands, neck, or jaw. This helps decrease your anxiety and frees your brain up to focus on the task at hand. Number 4, shift your weight. If you're standing, move your hips so your weight starts to alternate between your right and left foot. If you're sitting, move your shoulders backward and forward and feel your weight shift between your bum and your feet. Whether you're sitting or standing, make sure you keep your chest up and maintain a tall posture. Number 5, step or shoot up. In standing, drive one knee up and take a huge marching step forward. In sitting, drive your nose over your toes, reach forward, and shoot up, standing in one powerful motion. In both positions, try and make a large, exaggerated, powerful movement. So, what do you think? Did those techniques work for you? I really want to know. So leave me a comment in the comments.
That was awesome.
That was fantastic.
Yeah, I think that's really okay. And then I also found this. This is a bunch of other tips. Overcoming freezing is from parkinsonsdisease.net, and it's got a whole list of things to do. Humming or singing a song while walking, counting. I have a lot of patients that count, marching like 1, 2, 3, 4 to get unstuck. Using a metronome. Can you all hear me okay? Since I did the sharing. Okay. Changing direction, shifting your weight. Sarah talked about that. Marching in place, moving another part of your body. Imagine a line in front of you using a laser pointer. Practice dancing, exercise in intervals. So I thought these were good tips. And then I also wanted to point out, they mentioned the laser pointer. There is there are 2 devices. There's a Ustep, is a company that makes a walker and a cane, and they have this laser cane that when it hits the ground, it has a laser that goes across the floor, and you imagine stepping over it. So there's a laser cane, and then there's a laser walker also, same idea. The laser walker you can get with a metronome as well. So this is laser walker here. It has a cueing module. So a lot of people don't know about this, but anyway, there's more information, but I think that's really helpful too.
So that helps the shuffling.
Exactly.
Because you step over the line.
Yep.
Well, that was awesome. Thank you for sharing.
Sure, of course.
How new is that laser? How new is that the
Ustep?
cane?
Oh, it's been out a long time. I mean, I know. I started practicing 2007, and I know they had them then. So it's maybe 2008. I don't know, but around that time, I remember seeing patients with them. So It's been out for a while. And you can get it. I mean, again, talk to your neurologist. You can get the laser walker if you have insurance and a secondary insurance. It's almost 100% covered. It is an expensive product with a cueing module. I think it's around $800, but insurance will usually cover about $600 of it. If you get just a plain Ustep walker without the laser module and the cueing module, then it may be fully covered. The cane, I haven't put as many patients in for that just because it's less expensive, but I'm sure, again, you could get some insurance coverage. So you do, as a neurologist, you have to write a letter for the walker. You have to check off what patients are having problems with and how the Ustep walker will help them. But I mean, I think most of us have this. I have a templated letter and I just check off what the patient needs and then we send it in. They contact the patient. They usually get it within 2 weeks. So it's a pretty good deal.
So this is actually a question for me from working in the CAPS office. So if someone calls and asks, do you know where I can get a Ustep? If they haven't actually had a doctor's prescription, I guess maybe that should be something that I should ask them, because otherwise they should not be getting, I mean, without that, even if it's one that's on loan or something.
Sure.
Is that?
Yeah, I mean, I think, I think I always tell patients too, if they're looking at getting a walker and they need just a basic walker, it's probably better to get a basic one cheaper and just pay out of pocket. Because if you do want to get a Ustep later, save the money for that, because they kind of see all walkers as the same in many respects. And a lot of walkers you can get for $100 or $80.
Right,
And so if you're going to get a lightweight one, you can use the insurance on it. I think they'll pay for a walker every 3 years. But if you think you're going to want multiple, spend the insurance money on this one because you'll get better coverage. So, but you can always direct them to the website too. I think their customer service is really helpful.
Okay, yeah, because I do know that sometimes Ustep people, call, they want to donate one that they have, and if they're not, okay, awesome, great, thank you so much for that.
Sure.
Next question. I realize that Parkinson's disease is a degenerative neurological condition. Oh, that was a mouthful. Is it fatal?
It's a good question. So most patients with Parkinson's live a normal lifespan and they die of something else. Parkinson's does put people at higher risk of other things that can be fatal, including a fall. If you break your hip and then you end up in the hospital and then you get pneumonia and it becomes a series of things. If you swallow and you either choke or you get an aspiration pneumonia and can't recover from that. So, I know, and I get this brought up a lot in clinic, people say, I read the obituary and that said they died of Parkinson's. So most people don't really die of Parkinson's per se, but probably something that Parkinson's could have contributed to. But that being said, again, most patients do not die of Parkinson's, period. It's of something else, like cardiac or stroke or cancer, the top 3 causes that we all die from.
Well, thank you, Dr. Peckham. That was my question for my children.
Okay, you're admitting.
They keep insisting. Can Parkinson's be prevented?
I wish it could, but it can't be prevented. I always tell, families, if they're looking for something to do, exercise right now is the only neuroprotective thing we know of. So other than that, but if you do have a family history, or even if you don't, really exercise is good for everything. So, but there's no known prevention at this time.
No known prevention. How do I know if I'm a good candidate for deep brain stimulation surgery?
So deep brain stimulation surgery, the workup for that, it's a process. And I would say there's several things that go into it. When they did the initial trials about 25 years ago, what they really looked was basically for patients that had Parkinson's for 5 years or more, and that they were having off time or dyskinesias 3 up to 6 hours or more in a 24-hour period. We still use that similar criteria, although the 5 years is not a hard and fast rule. Some patients go to that sooner because they can't tolerate the oral medications. And it is a process in terms of, we always get neuropsychological testing to see if patients have any cognitive issues. That can be a contraindication. And I always do teaching with, there's 3 different companies that do DBS. So kind of try to find the right one for the patient and do teaching through them. You meet with the neurosurgeon. So in general, the motor part is off time or dyskinesia, but again, it is a process.
Okay. All right, so it's still brain surgery though.
It's still brain surgery. So that's, and I have a lot, this comes up a lot too, where patients say, well, how will I know? Well, I think, again, it's risk benefit with everything. It is brain surgery. It is a very long surgery. It's, when you look at neurosurgery, it's considered a more, I don't want to say routine, but kind of less fraught with complications, but you can still have them. And it is still, it is still a surgical procedure. So I think you have to be at that right time to do it. The other thing too, I didn't mention is if patients come in and their main complaint is that they have balance issues or they're falling, that's not really what we think about with Parkinson's and DBS. The patients that are good candidates are those that have either a resting tremor, slowness, stiffness, rather than balance issues. It can actually get worse. Balance can get worse with DBS.
Are there patients with that are candidates for the DBS surgery? Are there patients that are say a better patient or a better candidate for the DBS that's done when you're awake, or some that when you're asleep? Because I know they have the two different ones.
Yeah, there is the option. Yeah, kind of. So, it depends on where you live. I'll tell you, there are certain parts of the country where they're doing a lot of asleep DBS. Awake DBS is kind of the longer standing modality of doing it. It also depends on your surgeon. So there are some surgeons in town here that really only do awake, some that do asleep. And it's, when you talk to your neurologist, depending on what they're comfortable with. I think, for myself, I'm really much more comfortable with the awake DBS, because as good as the mapping can be, it's really nice when the probe goes in, they take electrical measurements at that time and they check the patient's symptoms. And if you're going to have that big and that involved of a surgery, I want to make sure that we're hitting the right target and that we're hitting it in the best possible way. So that's my personal bias. There are others, other movement disorder specialists around the country that argue that, you don't have to have that. And if the imaging is top notch, that you don't need that. DBS is just not something that I ever want people to have to do again. And so, that's kind of my take on it.
Mm-hmm. Thank you.
Thank you.
Sure.
What is the difference between the condition of essential tremors and Parkinson's disease?
Mm-hmm. So essential tremor, we typically think of as more of a task-related tremor. So when patients are writing, they notice shaking. When they're eating, when they're drinking, their hands will shake. Most commonly, it's in the hands. Parkinson's is really traditionally a resting tremor. So when they're sitting and their hands are completely at rest and they're completely relaxed, their hands or feet will shake. So that's kind of the I guess, black and white version to distinguish the two. The tricky part is sometimes when people come in, they do have both. One does not lead to the other, but you may have somebody that comes in and has had essential tremor for a long, long time. And then, boy, now their tremor's all of a sudden gotten worse and it's not being controlled with medications. And, oh, by the way, I'm having a harder time getting dressed and I'm slower. And then probably they're developing both. But one does not lead to the other. Both are more common as you get older.
But essential tremors is an action thing.
Action tremor, yep, action or task related. So people complain of, I can't put on my earrings, I can't shave, I can't put on makeup, I can't do mascara is a big one. When people try to do mascara, their hands will shake and they, they can't get it on, they get it all over their face. Eating and drinking.
I hate when that happens.
Yeah, I know. It's tough. But eating and drinking, people use, drink soup with two hands out of a cup rather than handling a spoon because there's spilled food everywhere. That's more essential tremor.
Do you have a question?
Let's see. No, I'm just question. Or it says there is a genetic link between ET and PD on LINGO1 gene. I don't know that that's a question, but let's see.
A comment, maybe.
Yeah, and of course, someone also said going back from certain things, you could also just sing and dance. I know, yeah, just sing and dance. We definitely do that. So I'm assuming that was just a comment. If someone linked LINGO1 gene, so yeah, okay.
Okay.
Next question then. Occasionally my balance is
Yep.
unsteady. Is there any medication that or exercise that can aid with this challenge?
So definitely exercise. There's, a couple different programs. One is the big physical therapy program that does work on a lot of balance exercises. I do send patients to physical therapy just specifically to work on balance, and there's a series of those as well. And then I think certain groups, I know the Fitness 413 in town, they work a lot on balance. There are other Parkinson's boxing groups that do a lot on balance. Medication, generally anything that's a levodopa compound is going to be helpful for balance. Not everybody. Balance is kind of a tricky thing because balance can certainly be a big part of Parkinson's, but again, as people get older and have more health conditions, if you have problems with your knees or your hips, or you've had prior surgery, or you have neuropathy in your feet, or you have problems with your ears or vestibular issues, there's so many things that contribute to balance. Visual input, if that changes, hearing. So there's a lot of factors that go into it.
Okay. And this is
That the
your
last
trial slide, Dr. Peckham.
Yeah, so
That was the
I
last
was
question that was submitted.
okay. I was just going to mention, so we do have right now 6 ongoing trials that we're recruiting patients with Parkinson's, if anybody has any interest. I would say in general, if you're interested in clinical trials, there's myself and then Dr. Swallow in Georgetown's doing a lot of trials as well. They're all different as far as the criteria. We've got a couple for patients newly diagnosed on no medications. We've got some for an earlier stage Parkinson's. We've got one that's for memory and balance issues and one for dyskinesia. We're also hoping in the next month or so to get one that's just for Parkinson's disease dementia and Lewy body dementia as a treatment for that. So if you're interested in clinical trials, there's a lot of ways to participate. I mean, we've got the centers here. Michael J. Fox Foundation does have online surveys as well. But I think the more, even if it's through the surveys with Michael J. Fox, the more information we can get, the better we can get at getting therapies for patients and better treatments.
So a question we have is, let's see, did we ask the question about running everywhere? So basically it kind of goes into the next, during off time, I tend to run everywhere. Why?
Yeah, that's kind of a classic Parkinson's symptom. So when patients are off, they tend to lose some of the postural stability. They tend to go up on their tiptoes and run really fast where they can't stop, oftentimes until they hit something, hit a wall or whatever's in the way. Some patients get frozen and stuck, but that running is a really classic Parkinson's symptom. And I think it has to do really just with the postural stability, how that changes with Parkinson's.
I didn't know that.
Mm-hmm.
This is great information. Great information. I'm just going to answer one question here real quick. I'm going to answer this question. Someone asked if this would be available to watch later, and I assume we can do this, Dr. Peck. I mean, yes,
That's fine with me. Sure, of course.
Yeah, we are definitely making this available, and we'll have this the slides obviously, and then we've got the links that Dr. Peckham has shared. So that answers your question. We will, yes, have it available. It may not be straight away, but definitely within the next several days. So.
And Dr. Becker, I hope you don't mind, but I included a slide that showed
Oh, very nice.
where you how to get in touch with you. Not to have tacos, but to get in touch with you. So this will be, as Mary says, available, so people can check it out. I'm sure you may have got some new interested people in seeing you.
Yeah.
Upcoming event on December 14th is Taco Tuesday, breakfast at Taco Deli on Burnett Road. So come join us for breakfast. We're paying for it.
Very nice.
Yeah.
And Snoopy, Woodstock, and Charlie Brown wish you a happy Thanksgiving. Thank you very much for coming today. I really appreciate it. And Dr. Peckham, you are unbelievably awesome. Thank you so much.
Thank you.
for
Thank
helping
you
us out.
so much, Dr. Peckham.
Yeah, of course. I'm happy to do it.
Is there any
Will you
last
come
minute?
back again?
Yep. Sounds good. Any one question, just one question that just needed to get out? I'll let Dr. Peckham go. She's got kiddos, but was there anything that we didn't? Now's your time. Okay. Okay. Well, thank you again so much. We just appreciate you. And yes, this will be available online, everybody. So we hope to see you at Taco Tuesday, December 14th. So
You're
at
welcome.
8:30 in the morning, and then you can go exercise it off.
8:30.
All righty. Thank you, everybody.
Thank
All
you,
right.
everybody.
Thanks,
Have a
everybody.
great
Happy Thanksgiving.
Thank you.
Thank you.
Okay.
Bye-bye.
Bye-bye.